So we do have a couple of questions from the audience. Perhaps I will start with Peter, with you. So there are a couple of questions from people with different types of EDS, like vascular EDS and periodontal, but it could also refer to other ones. What if we suspect as a patient that we have a certain type of a rare type of EDS? Who would be the first doctor, or what would be the first kind of doctor that we should see?
The primary physician, is usually the thing. But we think that one of the most important things is to have a primary physician, usually for adults who's trained as an internist as opposed to a family medicine, but it may not matter, and who is willing to learn. And we heard that story again and again. The person who's willing to learn and willing to understand about what's going on. That person then helps to make contact with all the other representative specialists.
Okay, thank you. And then I have a question for Dr. Neptune. So we've heard a lot about different respiratory problems, but there also was a question about sleep apnea in EDS. Is that a thing? Do we know about that?
Yeah, my group has done a lot of work with sleep apnea and Marfan syndrome, and we would love to know more about sleep apnea with the EDS subtypes, and there's just a paucity of information. And we're talking about how we link kind of the genes and the proteins and where they're expressed with the expected manifestations. And one would expect, because there's such a dramatic effect in other muscle beds, that there would be a susceptibility to sleep apnea, which affects kind of the upper airway, which is also a muscle bed. So we really invite information about sleep apnea diagnoses, kind of among patients with the EDS subtypes. Because one of the challenges that we find with Marfan syndrome is that physicians will often look at the patient and not see kind of a classic, what we call endotype, in terms of the way they look, as being reflective of sleep apnea susceptibility in the general population. And so they don't even bring it into the discussion when patients have symptoms that may be referable to sleep apnea. So give us the information, give us the data, and we will definitely advocate for more assertive sleep apnea screening. We just need data.
Yeah, and why would it be important to diagnose or know about it, or yeah?
So sleep apnea is one of those kind of systemically harmful diagnoses. And sleep apnea is the kind of disorder that if it's not diagnosed and it's severe enough, it can cause significant heart problems. In addition to kind of increase the risk of stroke, also kind of increase the risk of kind of a variety of kind of quality of life measures. So it's really important to make the diagnosis. And one of the things we find is that when it's appropriately treated, people have improved concentration, they have improved relationships, they have improved productivity, their lives are enhanced. So it's a critically important diagnosis to make, and fortunately it's vastly underdiagnosed, kind of even among people who don't have these concerning genetic disorders.
Okay, thank you. Then I have a question for Dr. Maitland. So there are a lot of questions actually about dental implants in different types of EDS and also in periodontal EDS. But as a general question, do we have information whether patients with EDS or with MCAS, whether what the success rate would be of dental implants in those conditions? Are there any specific recommendations that you know of?
Yeah, so actually some of the implants really have hypoallergenic materials. So they'll use titanium, for instance. And you can actually sort out, if you understand what the contents of the implants are, there are standardized patch testing that can identify contact allergens that can precipitate that issue. But I have to tell you, the dental community is actually quite on top of addressing that issue. You just need to work with an orthodontist who will then potentially work with an allergy immunology specialist who can then perform the testing to see whether or not the materials would be a problem or not.
Okay, thank you. Dominic, we heard about your China doll, and so question that we have, or perhaps you could share your experience. What advice would you give to parents with a child with a rare type of EDS, such as classical, but also other types of EDS that have fragile skin, who are trying to protect their child, but also who want to give them independence as an experienced person? What advice would you give to parents with a child with a new diagnosis?
I think it's important to think of precautionary measures and to allow them to do the same as everyone else, but with certain boundaries in place. I was always allowed to go out and do things with my friends, but there were maybe elements of the activity that I wasn't able to do, or I would maybe have to wear a shin guard or an elbow pad or a helmet depending on the activity. But as I got older, it was much easier to manage. I would say it's also important to give them an opportunity to find something that they're good at, and for me that was obviously expressive arts and writing and drama and art. And once I found talents within those areas, it made it much easier for me to accept that there were maybe other elements where I wasn't able to join in quite the same as what my peers could.
Okay, thank you. And then I have a question for Dr. Parakash. So for patients, the question is here for vascular EDS, but it would actually be important for all patients with EDS who have a risk for vascular ruptures, such as, for instance, also the kyphoscoliotic type. They also have an increased risk for arterial problems. So patients beginning an exercise program, would they have to have like 24-hour blood pressure or testing or any other testing done? What would the recommendation be?
My recommendation would be to begin at a very low intensity, especially it would depend on their baseline level of activity. If they are sedentary, it would be important to start very slowly, because we know that the endurance and strength build up quite quickly over time. But at that beginning phase, it's very easy to enter anaerobic or exhaustion quickly. And at that point, blood pressure can increase and heart rate can increase. We think that those are the kind of situations we're trying to avoid and maintain moderate intensity or low intensity to begin with. I think that for people who have significant goals in increasing their exercise, starting out with some sort of training or observation has two benefits. This is what we found in our clinic. People were afraid to exercise, but when we corrected them and we reinforced their activities, they became much more confident. And people would say after that exercise session, oh, okay, now I get it. I feel like I can go home and do this. It just took, maybe a half an hour observation with some people who are used to looking at exercise. It could be a physical trainer, it could be some in a clinical program, but I think that's very important if you're starting a new type of exercise in order to reinforce proper technique and safety. I think after that, it really depends upon the individual's progress, and there needs to be a lot of feedback about, or communication about, what is acceptable in terms of the speed at which one increases. But that kind of communication and a plan needs to come with the guidance of the care team, for sure.
Can you say what very slow means?
Yes. So what I would say is that if you are starting out, we provide weekly and monthly goals in terms of how many repetitions or how or speed changes you should make. An example would be on the treadmill in terms of the amount of time. So we gave our participants in the trial, they started out at 2 minutes, and we would give them both an intensity and time and a speed that they would try to reach at each 2-week increment in the study, and then they would report back to us on a monthly basis. So that went very slowly from 2 minutes to 4 minutes after 1 month, and then increased the speed at 2 months. We had a plan, and we would actually go over this with them and adjust based on their feedback. That sort of thing is very hard for people to do on their own because people get impatient. But if you're giving them feedback and you have a plan that you've gone over with them, it's easier for people, I think, to be motivated to stay with that. And we did see once we pointed out their progress in the sessions, that also had a huge effect on their confidence and made it easier for them as the study went on to participate and increase on their own. After a while, we didn't have to do that anymore. They were tracking and they were telling us, this is what I did, and feeling very, very confident and proud about it.
So we were talking about the periodontal Ehlers-Danlos syndrome and the ability to tolerate implants. My question is, for the patients that have periodontal Ehlers-Danlos syndrome, do they intervene knowing that that's the mutation? And then also, what kind of immunological workup are done on these patients to see whether or not things can be introduced?
My sense is that the vast majority of people who have periodontal EDS have not been identified. And part of it is because the dental community, it's not that they don't believe in genetics, but it's they don't see genetics as a component of what they practice, and they don't learn about genetics very much. So I would guess that the majority of people who have implants have them well before a diagnosis is made. And the group in Innsbruck have suggested that, in some of their families, implants predictably fail. And I don't know I don't know how much they do in terms of immunologic look or the kinds of structures on the implants and whether that makes a difference. But what they show is that you get this gradually widening area of demineralization and lack of mineralization, and the teeth just fall out.
The reason why I bring that up is, if you talk about other bone metabolism issues regarding osteopenia and osteoporosis, and what you can do to lead to balancing of the immune system, you can actually address the role of mast cell dysfunction in contributing to osteopenic and osteoporotic situations. And so I'm just wondering if you do a more complete evaluation as opposed to just landing on that diagnosis and then following the natural course, could you actually change that trajectory?
Yeah, I think that those are possible. I think one of the things that happens is that the C1R and C1Q, or C1R and C1S, apparently auto-activate.
Yes.
And they also change substrate, so that usually they're not in an area where they have collagen available, but they appear to be able to cleave collagens. And so you get almost a collagenase effect and a decrease in matrix. That seems independent of mast cell effects, a direct effect as a consequence of the mutation. Mast cells certainly, and then you get antigens and all those kinds of things that can stimulate the immune effects.
Okay, thank you. I would like to thank all the speakers. I think we need some coffee to digest all this information. So thank you again for wonderful talks, and we will see each other in about 25 minutes.